Welcome to the Rural Social Worker Closing the Gaps Despite the Distance podcast. I am your host, Andrea Charles, and this is the space where we will delve into the heart of rural landscapes and explore the essential role of social workers in bridging the gaps in rural social work. Join me as we navigate the unique challenges, celebrate the triumphs, and uncover the stories that shape the fabric of rural life. Together, let's embark on a journey to understand the transformative impact of social workers in the forgotten communities of our nation. A quick note, while our discussions provide valuable insight, please remember that this podcast is not a substitute for official supervision or guidance in your professional practice.
I am Dr. Jennifer Cork. I am a licensed clinical social worker and doctor of social work, and I specialize in treating neurodivergent clients in the mental health setting. So primarily autism, ADHD, intellectual disability, and I work with individuals of all ages. I like the variety of, maybe 1 hour being on the floor with kids and the next hour sitting up and at my chair having an adult conversation. And then I am also a late diagnosed autistic adult.
Okay. And for those listening, Jennifer and I also went and got our doctorate at the same place, so that's fun. Okay, so you're in Oregon now, but you were in Northern Idaho, and so we're going to talk more about Northern Idaho stuff, correct?
Right.
Okay.
Yes. So I'm not necessarily doing rural social work now, although I do have a few clients that I see on via telehealth that are in more rural parts of Oregon. But I grew up in a little town about 150 miles south of the Canadian border. It's called Laclede. It's not even technically a town.
Is that in Idaho?
Yes.
Oh my gosh, I haven't even heard of it.
It's in between Sandpoint and Priest River. So
Okay.
I went to school in Priest River, Idaho. It's about 8 miles away. So it was like, 45-minute bus ride to my school every day, K-12. And so initially when I graduated, we lived in the Moscow-Pullman area and then moved a couple years later to Coeur d'Alene. So Coeur d'Alene, Idaho is about 50,000 people, but I still was seeing it's still pretty rural, but also just because of my therapy specialty, there's not a lot of people that have the background in disability that I do. I was having people drive up to an hour just to see me. And so before going into social work, working in disability services and doing in-home and in community care. And so had people in very rural areas where, there was an emergency incident and it took a half an hour for the police to arrive, that kind of rural.
Yeah. So, and did you go to school in Moscow? I can't remember.
Yes.
That's where you got your bachelor's?
I got my bachelor's in elementary education at the University of Idaho.
So talk about maybe the population that you served primarily after you graduated with your master's. And I am curious if there was anything unique about the population you serve with being in rural areas.
So because I had worked in disability services for about 10 years, it just made sense when I transitioned after getting my MSW to working in mental health to continue to see the same clients. And so it really, that's when I first started working with disabled adults. So I was working with a lot of higher need, autistic and intellectually disabled adults, people who weren't able to live on their own, weren't their own guardians, along with the kids and teens I had already been working with. And I think one of the things that I noted right away was that the things that were bringing my clients in for mental health treatment, their anxiety, depression, maybe even their trauma, really had to do with the fact that society didn't understand or accommodate them appropriately. And so I joined the board of my local Autism Society of America affiliate, and through them, at that time, it was called the Panhandle Autism Society. Now it's Autism Society of Idaho. I was able to start doing a lot of community education and training. And so I think being in a rural area, when you're the person that will give free trainings, suddenly you're very in very high demand. And so just getting my name out there, was, I think, easier than in an urban area. But also being able to see the benefit of the work I was doing. I think that that was kind of a surprise. I wasn't the first one that had been doing that work. I kind of took on from other people that were nearing the end of their career. So the ground was laid, but then coming into Oregon and in the Salem area, I feel like everyone here is kind of behind on knowledge, but it had to do with the fact that it was easier in that rural area where they're so desperate for any kind of resources that it was easier to get out there and educate. And it wasn't, like I said, not just me. So I think that was easier in a rural area, but also through that training and education work, especially when I joined up with a member of the Coeur d'Alene Police Department to start doing first responder trainings. And I think we did trainings in 4 of Idaho's northern counties. And so that's where I would get all of these questions that would pop up where I would have no answer to and not even be aware that was an issue. I remember the first time we did our training was in Moscow, Idaho. Afterwards, we asked questions, and one of the officers said, "What do we do if we find a non-speaking or nonverbal adult that's wandering around the community and it's after 5 because everyone is closed and there's no one for us to call?" I just kind of stared because I had no idea. So I was able to then contact the Idaho Department of Health and Welfare and their disability program for adults and get them a resource. But even then, I remember feeling like it wasn't a great one. It was just the only one. And so you get a lot of that. On the other hand, because it is such a small community, and then when you get into the disability community, it's even smaller. Everyone kind of knows everyone. And so I remember one morning waking up and getting a text from the officer I did the trainings with. "Do you know who this person is?" They had found a non-speaking adult wandering around. And I knew exactly who it was, and I had his mom's phone numbers. "Oh yeah, that's so and so, and here's his mom's number." So because of that, we were able to get him home really quickly. And so it just things like that. But I think also, I'm thinking of one of the children I supported while I was getting my master's degree. I had to drive 45 minutes, on the highway and then on dirt roads. And every once in a while I would run into a moose in the road or something. And so I enjoyed working with her. She was a fun kid, but I know a lot of people had refused to continue services because they didn't want to do the drive. It kind of worked out for me because I would use that as study time, like listen to audiobooks and things while I was doing my master's degree. But, it can be really hard to connect to services, or you have to drive a really long ways. If a child, let's say, is getting services, and because of where she was located, she was going to two or three different towns, and her family was driving hundreds of miles a month just to connect her to services. That gets expensive and very time
If people
consuming.
can even afford a car to do that and gas
Right.
to do that.
And there's a point where, you have to have one parent that isn't working because they're spending all of their time driving their child to appointments. And so at the time, you were able to get reimbursed. They had a parent, like parents could be caregivers and get some of their time reimbursed through the state. But I know that the state of Idaho just rolled back that benefit. And so that just leaves parents that, their children need these services and they've just got to figure out how to make it work.
Yeah, I had my oldest is on the spectrum, and it took us till he was 15 to get diagnosed. And my youngest the other day, he came up to me. He's like, "I don't understand how you guys did it. Like, how did you get us to all these appointments?" Because we did, one of my kids had visual processing disorder. And so we did vision therapy, which is like OT for vision. And so he's just like, "How did you do that? How did you get us counseling? How did you, take care of all the medical stuff? And how did you do all of that?" And he goes, "I don't understand why people can't do it." Like he's talking about his friends, right? And I said, well, part of it is they don't know the resources exist. Like they don't
Mhm.
know where to go. They don't know how to advocate for what they need because in a rural area specifically, you have to push for those referrals. You have to ask for them and you have to do all those things. And I said, and also we have insurance. And so it made it a little bit easier for to doing that. But because of what I do, I knew like where to go and what to do and why this is important to help them at such a young age because early
Mhm.
intervention is huge. And if you don't have that means or access to those things to do those early interventions, it makes it really difficult as a parent, but also as providers who are working with this population.
Right. Absolutely. And I think too that, like you said, just knowing that the resources are out there and then figuring out how to get there is a whole nother thing. But I
Oh,
know one thing
definitely.
I have observed is that I feel like in rural areas that people are better at forming communities to
Oh,
help support, but it's almost like because they have to. So then moving to a more urban area where I had lived rurally basically all my life, it's like, where's the group for this or the group for that? And those kind of more community resources aren't as strong just because they don't need them as much. But it made it harder coming in to know where to point people, who to go to.
yeah, and that is one of the things I love about rural communities. I mean, if there's a fire or there's something, a family that's struggling, like, right, they all rally together and they help that person. And it's because everybody knows everybody, so they know what's going on. And so then it's like in your face, and people
Mhm.
are doing that more. I think for providers too that live in rural areas, so much of our job is case management that
Mhm.
we were talking before we got on here is you don't get paid for that.
Right.
And in urban areas, I don't think providers are doing case management. I don't think they might say, "Oh, you need this," but it's up to the parents or up to the client to go figure out how to get that. Whereas in a rural area, I know I personally will say, "You know what? I know this person. I'll reach out to him. Let's do an ROI. I'll reach out to him. We'll get you connected and kind of do that." Or, "Hey, I don't know where this resource is, but I'll look it up and I'll do the research and I'll do the legwork so we can figure it out."
Mhm.
And I don't know if why that's particularly different. I don't know. Well, I think one reason is people who live in rural areas struggle with trusting outsiders. And so if a
Absolutely.
person who lives in the community says, "Oh yeah, you can do this. This is somebody you can trust." They're more likely to do it. And so that's why I do some of the legwork. But the follow through I find is so much better if I do the legwork than if
Mhm.
if I do everything up to making the phone call, they'll make the phone call.
Yeah. Yeah, and I know when I was working in the rural areas, definitely doing that. I still do just because that's what I've done.
That's what you've always done. So you're just going to do it.
But I would even like, here's the resource. Do you want to make this call right now just to make sure that that you do it?
Yeah.
But it was definitely nice because you also kind of know everyone and you know the places that you feel like the client would do really well and you can connect them to that person. That makes it a lot easier, I think, than
If the resource exists, yes.
if the resource exists. And that's a really good point. I remember the Medicaid payer, they were rolling out a new service. They had rolled it out several months before this meeting, and they wanted providers to come and talk and learn about it to make sure that we were referring. And so they ran through it, and one of the resources that they were giving back to us was respite care for families. And so nobody was doing that. There was literally no one to refer anyone to, even though it had been available for several months. And so one of the reps had come from Boise, and if you're not familiar with Idaho, like the panhandle of Idaho, it's not even in the same time zone. It's about 8 hour drive from the capital. Very, very cut off and isolated from the more urban Boise area. So he's coming from Boise and he says, "What do you think about this program?" And I said, "Well, it sounds great. It's not available here." And he kind of looked at me and he said, "Well, I thought Coeur d'Alene was a bigger town." And I said, "Well, it is. That means it's even worse in the outlying areas." And he just stared at me and turned around and left.
I can think of one agency here in Lewiston, Clarkston doesn't count for this because it's in Washington, but in Lewiston, I can think of one place, and maybe there's more now, that ever did that offered respite. And so it was hard to find. I remember when I
Yeah.
worked for an agency, and the Medicaid there was peer support, there was respite, and there were some different things, but there weren't agencies that did it,
Mhm.
or there weren't very many.
Yeah. Well, and even testing, I worked for, the agency that I worked for had the only 2 child psychologists in the whole Northern
Huh.
Panhandle that saw Medicaid clients that saw children. So their wait list was, upwards of 9 months, and people would get really upset. It's like they
Well,
can
and
only
because
see
rightfully
people.
so, right? I mean, you need these things for school. I
Absolutely, that's
mean,
the
I have a
gatekeeping
parent
for.
right now trying to get a diagnosis so they can get their kid on a 504 and,
Yeah,
or an IEP, whatever one they need,
right.
based on their level of testing, but it's hard to get into testing
Mhm,
because we still don't have a ton. I was just talking to somebody out of Moscow who does testing, and she said that, something closed or something shut down, and so they've had just an influx of
mhm.
trying to get people in, and they're struggling with getting those people seen and in
Yeah,
and done, because when you have one person doing it, um, it's just difficult.
yeah. Well, and I would try to explain to people, like, they can only test so many people at a time. They're working. I knew how much they were working.
Mhm.
They were working a lot. So, but we had people coming from the Moscow, Lewiston area because they were the only 2. There may have been some additional resources in Lewiston,
My
but we had
understanding, there's only
everywhere.
been really one person, and he was in Clarkston,
Mhm.
that did testing, but when we got our son tested when he was in 2nd grade, it was a 6-month wait to get him tested,
Mhm. Yeah.
and I think it was longer for my older son when he was in kindergarten.
Yeah. And I know that was a barrier just for me personally. I had suspected my son was neurodivergent, and so the 2 psychs that did child testing couldn't test him because I worked with them. And so you
Uh-huh.
can't test kids you know. We couldn't afford to go and pay out of pocket in Spokane. They charged a lot more in Washington than we were charging in Idaho, and so it delayed. They were able to do some screening, which he passed, but you need the full the full testing for a reason. And so I kind of kept putting it off until we did move and saw he had more difficulties with things like transitions and social things when he had to make all new friends than we realized. But then we were in an area where, not everyone knew me, and so we could get resources. But I think that's another challenge that I have spoken to a lot of my peers that, let's say you or your child or your spouse needs therapy of some kind. When you're in a small area, everyone knows you, so nobody will see you or your family members. So that's a I think with telehealth, and which nobody was really doing in North Idaho in the pre-COVID era,
It's
then
still a
it's a
struggle
little better,
because
but
there's not internet providers that are
right,
consistent and able
right.
to maintain connection. I was doing a video call last night with somebody, and I'm like, "You know what? We gotta hang up. We gotta do a voice call. I'm sorry. I cannot
Yeah.
understand a word
I
you're
had that
saying."
happen quite a bit before I left, and I know this is a little off the subject, but my husband was working in the Silver Valley in the school system when they went into COVID lockdown, and I think 2/3 of his kids had no internet access, and so they're supposed to do rural, the virtual school with no internet. So they came up with a system where this actually helped them keep their parapros working and being able to be paid. But the parapros would drive flash drives around to all the kids' houses and pick up the week before all their work was on that flash drive. They'd give them a fresh one,
Okay. I know
and he was
here
like,
because I'm in Washington, I'm just across the border, but our school district loaned out hotspots
"Mhm."
for kids
Yeah,
that
I
didn't
think
have
they
it.
made the schools hotspots so people could come do schoolwork in the parking lot, but not everyone had parents that wanted to sit.
Yeah.
could go sit in their school parking lot or wanted to sit
And
in
I
the
think, telehealth, as we go on, I mean, I would assume technology will improve even in rural areas, but we are always behind, right? We don't have
right.
5G here, although sometimes my phone says it is. I don't really believe that it is. And I mean, we're way I remember when I got my phone and they're like, "Oh yeah, it's a 5G phone." I'm like, "Okay, but is it in this area?" And they're like, "Oh no, not yet. Sorry. It's
Right.
going to take some time. Maybe in a couple of years we'll get it
Right.
everywhere." But like my mom, so she lives outside of Lewiston, about 20 miles, and most of the time if I don't call her on FaceTime where it's connected to her Wi-Fi, I can't hardly hear her
Mhm.
because the cell service sucks. So you either have your internet sucks or your cell service sucks.
Right.
And I'm sure eventually in rural areas that will improve as technology improves, but I think rural areas are always years behind. I grew up, I was born in the 80s, but I grew up with a party line. I grew up with, we had dial up until I was way out of high school. Um, and
Right.
and I remember we did not have cable. We got one channel. I mean, and we had a beta. I mean, I just felt like we were way farther behind
Right.
these
Yeah, we
bigger
didn't
areas.
have street addresses until after I graduated high school. I graduated in 97.
I remember when they did the GPS addresses because we had a rural route before then.
Yeah, we didn't have 911 services, but then they passed a thing saying that we would. So if you called 911, you would get somewhere really far away. Like there wasn't even no guarantee like where it would be. We just kind of knew that wasn't a resource. There was no fire department, no emergency services. So there was no reason for street addresses. Everybody had to go out and name their streets, and because a lot of them didn't have names. I think my in-laws only got rid of their dial-up like within the last 5 years.
Yeah, my parents didn't even have they had limited internet for probably up until about 2-3 years ago. And so like if my niece or nephews were out there or my kids were out there and they watched a video, then your internet's done for the month.
Right.
And you could get no more. And I think that's a barrier. And I think, because of wrapping back around to the kind of the case management piece of it, I think, in some of the research that I did when I started this podcast, a lot of the burnout exists from this extra work that we have to do
Right.
and this extra stuff we have to do. And the feeling of being alone too, because,
Right.
there's upsides to being in a small community. Like I can call in favors if I need something, like if I need somebody seen urgently or whatever, I'm like, hey,
Right.
this is why. I can argue it or whatever.
Right.
Can't do that in a bigger area. So there is positives to that. But if there's no resource that exists and you're not
Right.
willing to create that resource, it makes it very difficult. And if you create
Yeah,
the resource, then you can get exhausted from that.
absolutely. And I think that's the hard thing where you are required or not required, but your clients do better if you do that case management,
Uh-huh.
collaboration with other providers. And that's with the neurodivergent population, depending on their level of support needs. They're seeing, 5 different professionals in addition to their primary care physician.
Yeah.
And so, they do better if everyone's working together rather than I'm introducing one thing and their OT is introducing something else and their speech therapist has a third thing. So if we can all coordinate and use the same words and language and things like that, and the system isn't reimbursing for that, so you're just doing that on your own time, that definitely leads to burnout. And I was really thankful kind of early in my social work career. I had a mentor that she was an LMFT, but she had worked in disability services or through the state, Idaho Health and Welfare. And so I would go to her with a lot of questions about adult services because she knew more about it than I did. And she was really good at like sensing like my desire as a social worker to do systems work and the risk of burnout. And so she would say, okay, here's the person that you contact, here's like, kind of word it this way, then and then your job is done. You need to let other people do their jobs. And so that was really helpful. I would as I would kind of dive into but I need to make sure that this happens and that happens. And I would hear her voice in my head saying,
Your job is
and then
done.
your job is done. You did what you were supposed to do. You need to let other people do their jobs.
Mhm.
But sometimes even then that was really hard when I knew other people weren't doing their own jobs. And with me offering that community training, I did almost all of it for free, although my employer, she found it very valuable. And so she would pay for my time if it fell within my normal work hours. But people were so under resourced. The reimbursement rates for all the services are so low. Nobody has a lot of overhead. And so nobody could afford to pay me for my time. But then everyone wanted me to come and do trainings. And I had to learn to start saying no. It was really helpful when I started. We have a Croc center, had a Croc center in Coeur d'Alene. I guess it's still there. And they had me do my Autism 101 and ADHD 101 trainings twice a year. And so then I could say, no, I won't come do my autism training, but I'm going to do it in a month and a half. And you can go to for free there. And so that was helpful. But even then, I had people yell at me like I was a terrible person because I wasn't willing to go do it just for that particular organization for free on my on my own time.
What did you do to kind of help prevent your own burnout or if you were feeling burnout or overwhelmed doing all of the, creating those trainings, but also being a resource and doing all the systems work? Did you have anything that you did to help kind of balance that out?
One of the things I did was go down to a 4-day work week with clients. And so that fifth day left me time for catching up with paperwork or I would leave the trainings and things for that day. That's something I still do. But also just learning to limit the number of free trainings that I would do, taking personal days just where I did nothing. So trying to do that, but also I honestly think it was helpful that as an autistic adult, even though at the time I didn't know that I was autistic, that, this was very much a special interest for me. And so that in itself, like going and doing a 2-hour info dump was in a way re-energizing for me.
Yeah, that's something that I tell people who work for me is niche down, get really good at what you love to do because
Yeah.
A, it's less burnout to do that. But B,
Yeah.
you get really good at that thing and then you're the go-to person for that thing. You'll never worry about being busy. You'll never worry
Right.
about having enough clients. But also, I think it connects you more to your community because they're like, no, this person knows what they're talking about. And so even if you didn't grow up there or you came in late or whatever, you've never been in a rural community, it gives you an in. It gives you
Mhm.
a connection to the community and bringing something they need to them.
Yeah, absolutely. And I think also that because I was in a small community and could see the benefit, and to have people reaching out to me, and then also just when I started being more well known, other people started taking the same track that I did. Coming from disability services, going into mental health, and then I wasn't the only one. And so then it was nice to be able to say, hey, I have a really long wait list, but this person's also very
Mhm.
skilled and has a similar background and training, professional training that I do. You can go see them. And so I think there's that benefit, but definitely, like I said, seeing the outcomes. Like when we were doing the law enforcement training, I would have people that didn't know I was doing that would come and say oh, my daughter had a meltdown. We had to call law enforcement. And they were so much more patient than the last time we had to call. They asked a lot of questions. They really helped de-escalate the situation. It was such a great experience. And then, I would be able to say oh, that's because they just had this training with me and an officer Gus.
So what would you say to either new people graduating, new people coming into this area, people who've never lived in rural areas coming to rural areas, what is going to help them be successful in the long run?
So I think whether you're in an urban or rural area, I like what you said about just finding your niche and really sticking with that. But then, finding your people. I treat OCD along with neurodivergent individuals, partially because there was a lot of crossover. And so moving to Salem, there's only two other providers that treat OCD in the whole city of Salem. And so we get together periodically to support each other. We do referrals between the three of us, and just finding like who are your people and your resources, regardless of where you live. I think also making sure that you have those boundaries for yourself. You need to maybe do the consultations and the systems work, but not doing it to the detriment of yourself. And so I think maybe even having a supervisor or a colleague that does what my mentor had done, with saying like, your job is done. Like, you need
And
to
the
let
research
go.
says like supervision is like one of the biggest things to help prevent burnout is just having
Right.
somebody else to talk to. One thing that I've done is I create like master lists. And so like if I've made a referral or I found a resource, like I'm going to put it on the list, because then the next time I'm not searching for it and I'm not trying to find it. Like
Yeah.
that legwork is done in that.
Yeah. I do that same thing. So I also would recommend, just since representing my therapy, my client population, making sure as you're coming into the social work profession that you do have some knowledge and competency on neurodivergent people, and what that intersectionality of disability and mental health looks like. And in the research for my doctoral capstone, the rate of co-occurring mental health diagnoses is super high. It's 70% in the autistic population will qualify for at least one mental health diagnosis. 50% or more qualify for two or more. For ADHD, it's close to 80% co-occurrence. For the intellectual disability population, it's 35%. There, the numbers are a little bit less clear just because there's not as much research, but about 35% of intellectually disabled individuals have a mental health diagnosis. But then when you look at the professional, like the therapy population, one of the studies that I read, the research team called over 8,000 clinics across the United States, and 53% of them said that if a child was referred to them with an autism diagnosis, they would not take them. And only 12% had a therapist with any kind of training or competency experience treating autistic individuals. And I see all of the time that people coming to me that have seen other therapists is, maybe they weren't successful in therapy, and it wasn't because of the modality necessarily, or that the person didn't need help, or that they were non-compliant or anything. It was really having to do with the fact that the therapist didn't understand how autism interacted with depression, anxiety, PTSD. And so there's a huge need for the neurodivergent population to have competent treatment providers, but there's very little instruction in master's or doctoral programs on what that looks like. There's no evidence-based treatment modalities for the autism population or the intellectually disabled population. And it's partially because we've only just recognized that disabled people can have mental health diagnoses. When I started researching this topic in my master's program, I found very little prior to 2007 that was even exploring that co-occurring diagnoses. So that would be, I'd like to change the culture of mental health, probably not all by myself, but help make that change. Just like with trauma, like you're not necessarily expected to be a trauma specialist,
Right.
but every therapist is expected to have some level of competency treating people with trauma, and having it be the same way that because if you work in mental health, you are seeing neurodivergent people. They may not have diagnoses, but you are. And I think I just read a study that said like 1 in 5 people in the mental health system have an undiagnosed neurodivergent or neurodevelopmental disability. So maybe ADHD, maybe autism, something along those lines. So whether or not you know it, you are seeing neurodivergent people. So you need to have some level of understanding and competency.
Yeah, I agree. I mean, we have so much around trauma informed care, but we don't have any information around how to work with neurodivergence on a regular basis. And there's ways to tweak things. Like I tweak EMDR, a little bit if I'm working with someone with neurodivergence than I am with somebody who doesn't have. Yeah, there's a lot of lack of training,
Hmm.
and I think one thing that I think for people to do is like don't be afraid to create the programs, right? Don't be afraid to
Hmm.
lead those things and to have those things. I think it can be difficult, but it can really be fruitful for rural communities specific.
Absolutely.
Is there anything else you want to make sure we talked about that I missed?
So, on the note of lack of resources for treating the neurodivergent population, I actually have a therapy book that's coming out in October 29th, I think is the projected date. So it'll be released in paperback, hardback, and an ebook through Routledge Press. It's called What's Your Anxiety Level? Cognitive Behavior Therapy for Children and Teens with Co-occurring Anxiety Disorders. You just remember the title, what's your anxiety level? You'll be able to find it. But it is a 16-week curriculum for treating neurodivergent kids and teens specific with anxiety disorders. And it really came from a place where there weren't a lot of resources when I graduated and started working in mental health. And so I took what I knew from my ed degree, what I had studied, on what worked with autistic people in mental health. There was very little research at that time, and I just built my own treatment intervention. And so my husband, like, as I started being really successful with this, he kept bugging me to try to get it published. And I said, nobody's going to publish a random LCSW from North Idaho. And then I finally said, fine, I'll go get my doctoral degree, then I can work on it some more. and and then try to get it published. And so that's what I did. This is part of my capstone project, was working on this book. And I was able to get a publisher to pick it up. So
It's awesome.
yeah. And I wrote it. It's not necessarily for um to use in the rural setting, but it was written and developed in a rural setting. And so, but with the idea that it could be used for people that were working within multiple systems. So whether it's in school, other therapies, um, sports, Girl Scouts, Boy Scouts, whatever, was made to be able to be used in all settings and to be something that the parents could use easily at home. And so I'd love everybody to check that out.
Yeah. Do
And as
you
far as I know,
offer consultation or supervision on this subject?
I do. So
Okay.
I offer both. And I am a registered supervisor in both Idaho and Oregon.
Okay. So if somebody lives in Idaho or just wants to consult with you, like what is the best way to get a hold of you?
So if you go to my website, acceptancementalhealth.com is for my therapy practice, and also drjennifercork.com. You can connect with me in either of those places. I also list a lot of the trainings that I do on my unacceptancementalhealth.com. It's my goal to help people get that additional knowledge and training to treat neurodivergent individuals. So I'm doing a training October 17th from 9 a.m. to 12 p.m. Pacific time through the Western Oregon Mental Health Alliance. And that's a 3-hour training that focuses on treating the intersectionality of neurodivergence and mental health. And so again, if you're listening after October 17th, I do try to list the trainings that I'm doing.
Yeah, this won't actually probably go out until the beginning of the year.
Okay.
Because
Well, then I can put that out.
I took a break. Like it took 2 months off, and then I have 3 already recorded for October, November, December.
Okay.
Because I do one a month. It's just too hard to do more than that.
Okay.
So probably January, February, but
Okay.
all of
Well,
it
then I
also
have,
will be listed in the show notes too. Of like, we'll
okay.
put your websites in there. We'll put all the
Right. So I do have a training coming in March 13th through the Arc of Oregon.
okay.
That's a 6-hour training treating neurodivergent clients in the mental health setting. And that will have continuing ed credits for 6 CEUs in cultural competency, which in Oregon, at least, you have to have a certain number to re-up your license in cultural competency. And that's, again, March 13th through the Arc of Oregon.
Okay. Awesome. Well, thank you so much for joining us. This is great.
Thank you.
If there are stories or issues that you face in your practice and you would like me to discuss those on this podcast, please send me a message at theruralsocialworker@gmail.com, and I will be happy to take a look. One of the goals of this podcast is storytelling, and I believe that to be impactful, you need context, and that is where stories come in. They give us something to work with and something to build on. I also believe that stories from multiple different rural communities will offer more information and provide more support to rural social workers everywhere. So with that said, I hope you enjoyed this episode and will subscribe for more. Thank you for joining me for another insightful episode of The Rural Social Worker. If you've enjoyed our exploration into the vital work of social work in rural communities, be sure to subscribe, share, and connect with me on social media. Your support helps me continue my mission of closing the gaps and fostering resilience in the places that often go unnoticed. Remember, this podcast is not a substitute for official supervision in your professional journey. Until next time, stay engaged, stay informed, and keep making a difference in rural communities.